very interactive session for all of us to learn more about how to do SDOH trainings with our populations. Again, if you're not, I ask that you all please place yourself on mute so that we can be able to hear one another clearly. All right, so this is the project team at NACC and AAPCHO. This is a long-standing partnership between two organizations, between us at NACC as well as AAPCHO. And we did want to mention that Michelle Proser, she has left NACC. So she's formerly the director of research, and she has, you know, she's at another opportunity right now, but we just want to acknowledge her and thank her for all of her efforts. But here's the rest of the team. We're all here ready and willing to help you all with any of your needs. So I wanted to provide a very quick high-level overview over the efforts that we've been doing since this January. I can't believe it's this past January. But we wanted to acknowledge our TTA partners who have worked with us for the last couple of months. We've had several PCAs and health center, primary care association and health center controlled networks join us, as well as the following national training and technical assistant partners. I'm not going to list all their names, but they've been wonderful partners in this venture with us. And this has really been a joint effort through all of us. Next, we also wanted to acknowledge our community health center stakeholders, our partners at the PCAs, HCCNs, and NTAPs. They were able to identify these wonderful community health centers that work with us to just learn a little bit more about their efforts to collect SDOH data and address the SDOH needs of their patients at their health centers. So for this, we want to get a sense of who's in the room. So right now we're going to launch a poll. So if you can take a quick moment just to identify which statement best describes your organization type, that would be great. And again, it's just to get a sense of who's in the room. It's always nice to just see all the different partners that are attending our webinars. We'll give a couple more seconds for folks to respond. And once we are done with the poll, if we can share the results just to get a quick glimpse as to who's in the room, that'd be great. Oh, wonderful. We've got a wonderful array of different partners in the room, so to speak. So it looks like we have a large majority of community health centers, and then we've got primary care associations, NTAPs, health center control networks, as well as government officials, academic institutions, community-based organizations, and folks that identify as other. Great. Well, welcome to today's webinar. We hope you definitely have an opportunity to learn more about, you know, how to screen for SDOH needs amongst our patients. So thank you. All right. So these are the learning objectives for today's webinar. We want to provide you all with the opportunity to learn about existing and emerging SDOH screening, training, and technical assistance strategies at health centers. We want to provide an overview or preview of an upcoming publication. This publication will have insights and strategies that we've gained from the needs assessment as well as the listening sessions. And then finally, we want to provide some time and space for discussing specific SDOH screening needs for special and vulnerable populations with subject matter experts. All right, so here's the first learning objective. If you missed it, we did a webinar last month and it provided a more in-depth overview in terms of the project that we're working on. And this was last month. And I'm just clicking through, okay. And so this is just a description of the webinar that took place last month, and that's the bit.ly link to the recording. So if you missed the first webinar, please feel free to catch that later. And of course, we'll be recording this session today. So if you had to hop off later or you want to share it with others, please do so. For some reason, my slides are not All right, there we go. For some reason, things were frozen. All right, so this is the overarching why. So structural racism describes the way our systems are structured to produce racial inequalities between white populations and racial and ethnic minorities in the social determinants of health, leading to racial health disparities. And this is a quote by Ruqayya Yerbi. Sorry, my apologies for messing up their name. They're from the Center for Health Law Studies of St. Louis University, and they're the executive director and co-founder of the Institute for Healing, Justice, and Equity. So as community health centers and community-based organizations possess the knowledge, skills, and abilities in serving communities that are made vulnerable due to systems, and the systems include education, criminal justice, employment, housing, and healthcare system. And these systems, by law and regulation, have been structured in a way to racially discriminate in a very racial discriminatory way. So as health centers, you may either bear witness to or have even researched different forms of structural discrimination, such as racism, sexism, homophobia, ableism, ageism, xenophobia, and classism. As you can see through this diagram, the structural discrimination that we see is the root cause, right? And then there's different tools that are used to actually make this happen. This didn't happen by accident. So there are different structures in place that I mentioned before: political, educational, regulatory systems that are all working to discriminate against different people for a variety of reasons. But the outcome that we see is in the health and well-being of our communities. So with that notion in mind, our teams at AAPCHO and NACC believe that in order to achieve racial health equity, we need systems to work proactively to end structural racism and discrimination, and to revise the laws and regulations that create racial inequalities and health disparities. As training and technical assistance providers, we have the power, privilege, and responsibility to guide the health centers that we serve to be able to assess for social risk factors that patients and vulnerable community members experience, especially during the COVID-19 pandemic. And with this social risk assessment data, we would be able to utilize at the individual level in terms of improving patient care, and then the organizational level to design, this could be designing care teams, and then moving our way up to system and community levels, which would lead to changes in local policies. And then we have payer levels, and this is where we would be able to create payment models that sustain value-based care. And then finally, at the policy level, to ensure that, that there is capacity for serving and caring for complex patients. And while all levels are important, it is at the policy level where we can truly begin to work towards improving the health and well-being of racial and ethnic minorities, and thus truly achieving racial health equity. So in terms of the different stakeholders within this ecosystem that we work within, we understand and we recognize that there are stakeholders at the local, state, federal, and regional levels. And each of the stakeholders play a very critical role in serving the needs of our community. So that it could be at the health centers, at the PCAs and HCCNs, at NTAPs, and then BIPIC and other federal partners. We all play a role in terms of what we can do to advance health equity. So throughout this project, really the purpose of this project, we wanted to really get an understanding in terms of what are the screening strategies that are used to assess and address the SDOH needs of patients. And we wanted to use this information to inform our training and technical assistance strategies. So this time frame has really been, it started technically in January, but we really had a deep dive into the work in February and really up through April. And the target population of this work has been NTAPs, PCAs, and HCCNs. And what this project really consisted of was an online questionnaire, a needs assessment to really get an understanding of what the current work was currently happening. But then we also conducted listening sessions with community health centers just to validate some of those findings, but to also learn more about their needs and their strategies to addressing the social determinants of health risks of our patients. So in our needs assessment, these are some of the questions, or are actually the categories that we looked at. So the first question that we looked at was, what are the challenges that your organization has encountered in supporting health centers and implementing patient-level SDOH screening. And we looked at these 3 different buckets in terms of assessing, which is really looking at coding, data collection, that behind-the-scenes infrastructure of collecting this data. The next piece was operational, and this is actually what are the strategies to get to implement this work, right? What are the workflows? What are the staffing models that are used to actually conduct these screenings with our patients? And then the third bucket of work was around responding to this data, which is critical, right? We want to be able to collect the data, but then we need to respond to this data. And then the other question that we looked at was what strategies you're using to currently support the implementation of SDOH screening at health centers. So this is a breakdown of the individuals or the organizations that responded. I'm not going to go through too much information here, but we had a good array of different TTA providers that responded to the needs assessment. And then these were some of the findings from the needs assessment. And we wanted to just provide a very, again, high-level overview. Some of the themes that really emerged was, there were some challenges in terms of asking some of the questions. Maybe there was no clear strategy for supporting this work. And then I would say probably the other important piece was really the biggest challenge is sharing this data with community partners. And as community health centers, we understand that a lot of the care that we deliver is outside of the walls of a health center. So being able to share this data with community partners is really critical in ensuring that the needs of our community are being met. So this was a common challenge amongst all of our survey responses. So these are just some of the high-level results in terms of what we heard from the field. There is a lot of need around understanding how to really screen for SDOH. So this again includes workflows, increasing staff buy-in, and sometimes that would include leadership buy-in as well. Being able to have impact stories and then best practices and lessons learned. This would be really helpful to health centers. Some of the upstream opportunities that were identified were demonstrating value, helping in terms of advocacy efforts, in terms of how to work within the community and working with community partners, and then risk stratification, how to use this information within the EHR so that we're not only having risk stratification models that include clinical data, but also SDOH data as well. And then in terms of TTA strategies, probably the biggest one that we heard was peer sharing and learning. So having this done by groups, depending on the different levels of readiness within different health centers. And then when we had our listening sessions with the community health centers, we dug a little deeper in terms of what were the best ways to provide TTA to them. Loud and clear was peer-to-peer collaborative learning, really allowing and creating that space so that we can have collaborative learning amongst the peers. Identifying tools that can be used in working with interdisciplinary team members. As we continue to move more in a value-based team model, our value-based care model, is really important to have interdisciplinary team members so that everyone has a different role in providing care for our patients. The next strategy was hands-on and in-person training. And obviously, once we're able to do that, we will definitely try to do that. But really, how do we provide that space and time to allow health centers to really get that hands-on training? And then we have focused training, so really identifying what are the key issues most prevalent to the patient population. For example, we heard from health centers that care for agricultural workers, and they identified some really interesting strategies or needs that they have, which you'll hear a little bit more, you'll see more in the publication. But really, we heard from the health centers and they said, really focus in on the needs of the different patient populations that we serve and really base the trainings around that. And then finally, self-paced online trainings. We know everyone's really busy. So being able to have this opportunity to do trainings at your own pace will help not just with current staff, but even new staff as they join your health center. So now I'm going to hand things over to Albert. And if there's any questions, please pop them in the chat or go on mute. But I'm going to stop sharing. And if folks have any questions, please feel free to ask.
Thanks so much, Rico. Oh, I hope there's no echo on my end. Okay. So we're going to get through just a quick update on the publication that Yuriko mentioned, which was a big partnership between AAPCHO, NAC, and all the stakeholders that Yuriko mentioned at the beginning. And so we want to acknowledge all the great contributions from the needs assessment to the listening sessions. And then today is just a way to validate those findings with you all and kind of garner additional insights, because we know that HRSA is always looking for ways for all of us to collaborate and share information. So these webinars and meeting sessions are always a great opportunity to do that work. So let me share my screen. And does that show the meeting notes section? I hope that's, oh, yeah.
It always does the presenter view, not the, there you go.
There we go. It always does that. I need to change. Someone needs to give me TA on PowerPoint. So just to start off with the publication goal, again, this is a publication that's undergoing review by the Bureau of Primary Healthcare right now. And so we hope to release that later this summer. But the goal of this is to provide, again, a glimpse for NTAPs, or the National Training and Technical Assistance Partners, PCAs, Primary Care Associations, and then the HCCNs, or the Health Center Control Networks, ways to increase their strategies or improve their strategies to support you all, the health centers, in documenting SDOH. And that's done through, again, standardized screeners, like, again, the Accountable Health Communities tool, Health Leads, PRAPARE, WellRx. There's so many tools out there. So the goal is to really standardize your data. That way you can pull reports and share reports with not just your health center colleagues, but outside of your health center. That could be with a community-based partner, that could be with your policy maker, or even your payer, which is going to help drive the conversation around sustainable and reimbursement for the work that you're doing that's non-clinical in nature. And so we're going to, again, really help you kind of figure out ways to tailor your TTA. And without the health centers at the table, again, and I'm loving that we're seeing some health centers in the room today, we want to make sure that we're all having conversations and providing rapid feedback, because sometimes we're given kind of those needs assessments on an annual basis, but things change on a day-to-day basis. So we'd like to do our best to ensure that we're providing these open forums. And so the other half of this presentation will be really focused on breakout rooms and ensuring that you all have the space to talk to some subject matter experts from the training and technical assistance space. And a lot of this was driven, again, by the COVID-19 pandemic, which we're still experiencing a lot of, again, issues around equitable vaccination and distribution, not just domestically now, but globally. Also the need to talk about kind of the racial and ethnic unrest happening in our country, in the US. And so really SDOH is only going to become more and more common in our day-to-day work at the health centers and also at the NTAP, PCA, and HCCN levels. So again, the goal is collaboration and communication through this publication and the work we're doing. In terms of the structure of this publication, you're going to find an overview of what NTAPs, PCAs, and HCCNs do. You're going to also find, again, an overview of what we gleaned from the needs assessment that we launched in March, some specific workflows or just ways to devise a workflow in your own settings, because we know that not all workflows are applicable in the settings that we're in, whether we're in a urban, suburban, rural setting, geographically speaking, or if perhaps you're working with large health centers versus small health centers. We know that staffing and workforce is a issue of capacity and whether or not you can deploy certain workforce types to do your SDOH screening and assessments. And then lastly, we'll talk about some other additional topics around screening strategies related to COVID and after COVID, and the recommendations by different special and vulnerable populations types. And you'll get, again, a nice glimpse of that in the publication with all the different TTA providers at the table. And this publication is not going to be full-on narratives. We actually distilled a lot of key insights and quotes from our health center participants and also from our PCA, NTAP, and HCCN stakeholders who participated in meetings and also the needs assessment. So just in awareness and also acknowledgement of Pride Month, we chose kind of a focus on the Power Pack, focused on the LGBTQIA+ populations. And our key stakeholder from the NTAP space here is the National LGBTQIA+ Health Education Center, also known as Fenway Institute. And in the needs assessments and the CHC listening sessions where health centers were focused on this population, there was a really big focus on intersectionality and acknowledging the patient's full background. And again, this applies to all our other special and vulnerable populations too. We know that patients can have multiple identities at the table when they come and visit your health center. So really painting a fuller picture, and that SDOH data is meant to help paint that fuller picture of your patients and populations that you serve in your community. And one of the quotes from a health center, I just want to read out loud here, is, "It is important to facilitate training sessions that focus on the intersectionality of people. We need to consider how much we factor intersectionality of identities for people and how to make referrals where they feel comfortable following up on." This one was huge because talking about the quality of referrals, you might have a resource guide that might be outdated, or maybe that community partner is no longer able to provide services for your patients. And so not just screening, but really following up on your referrals process is going to be even more important if you're going to be affirming your patients' needs around, again, where they're comfortable getting their additional support if it's not at the health center. And in this SDOH work, we're seeing a lot of partnership building more and more because health centers may not be able to do it alone. So then you might find yourself signing business agreements or memorandum of understanding to ensure that you have your partnership acknowledged in your local community. And again, it's encouraged too, because sometimes you want to focus on just clinical care and then have key partners focus on the social services care. So however you do it, it's important to kind of acknowledge the strengths of your staff, your patients, even in their own self-empowerment, and also your community partners in the work. In terms of another quote and example from the PRAPARE here is kind of a focus on technology. So leveraging technology to initiate referrals prior to connecting with providers. So one of the key quotes under this is, "It is recommended to pilot workflows that direct patients to a website resource and or a referral directly through their mobile phone, so that the patient can begin the process of responding to a social need until a case manager is available. This allows the opportunity for patients to be referred immediately after SDOH screening and using technology to increase capacity for staff." And I was just on a recent call with a key partner at the Health Outreach Partners. I think I see Cindy Selmy here in the room today. We were talking about just increasing patient literacy, but not just patient literacy, but digital literacy, given that we're increasing the telehealth, the telemedicine visits at the health centers. So finding ways to increase your technological capacity might help improve efficiency and your bandwidth for your staff who are working with patients remotely speaking. And the in-person is not going to go away either. So that hybrid model is going to be another key approach to figuring out ways to meet your patients where they're at, because they might not want to come in now that they're used to doing telehealth with your case managers or clinical providers. So in any case, use technology, but also kind of check with your patients what they prefer. So patient preference being key. And the last quote I want to share just from a snippet of the PRAPARE is closing the loop. We heard this on and on again, not just in the needs assessment, but throughout the listening sessions, is once you do screening and you have your patients identified social needs and social risks, kind of what's next? And what's next is you start referring to an in-house resource or in-house staff member that can help that patient. And you might be doing it also externally and referring your patients out of the clinic into a community-based organization or social services organization. So with closing the loop, one of the key themes here was just how do you follow up with patients and measure the impact of your referrals? We know that's already a struggle for even doing specialty referrals for patients. So how do we apply that kind of same framework and workflow to your community social service referrals? And one of the key quotes we want to distill here is, it is important to acknowledge that SDOH screening implementation allows you to connect the dots between patient needs and resources available at your clinic and or in your community. It is recommended to keep track of services that patients are referred to. And it is easy to make a referral, and we should be mindful of the amount of time it takes for staff to follow up if the referral still offers a service and who is eligible for those services. And I want to point out that time it takes, because we know that sometimes an outreach worker or outreach specialist may be spending 60 minutes with a patient just to go through all their social needs. And that means a lot of different referrals, whether that's in-house or externally. And so how do you follow up on, let's say, 4 social determinants of health needs with 1 patient times all the patients that you have who had identified a social need? So figuring out a workflow that works for you all is going to be key to closing the loop. And we have heard from health centers who are using different pop health tools, the Tableau, the Zaras in the room. Being able to have some reports available to your staff is going to be also helpful to ensure that data is transparent and shared across the organization. So with that, I just want to acknowledge all the stakeholders who have contributed again to a lot of the publication. Again, the NTAPs, the PCAs, HACNs, and our 22 health centers across the country. This wouldn't be possible without you all. And with that, we're going to allow you all to kind of talk to some subject matter experts across the country who are focused on different special and vulnerable populations. And I want to acknowledge here, we're going to be having 8 breakout rooms. The main room here will be the national perspective, and you'll be sticking around with the AAPCHO, NACC, and also our partners at the National Center for Equitable Care for the Elders. So that's Ariel Mather. If you choose to go focus on state and regional perspectives, so for you PCAs and HCCNs in the room, you'll be with Heather Adams from the Community Healthcare Association of Connecticut. But I also want to acknowledge that we have the Missouri PCA and the Arizona Alliance for Community Health Centers who are part of our stakeholder group. So I think I see Lindsay from Arizona in the participant list. But feel free to go to that if you want to kind of talk shop and figure out ways to work better together across your PCA and HCCN. And Heather has worked under both the HCCN and PCA grants, so she is an expert in all sorts of ways. And for those of you who want to focus on individuals or families experiencing homelessness, you'll be with Jamie Blackburn at the Corporation for Supportive Housing. Also acknowledge that we have the National Healthcare for the Homeless Council as another NTAP who serves as a subject matter expert. So feel free to go join that group if you want to focus on homelessness. For intimate partner violence, we have Lisa James from the National Health Network on Intimate Partner Violence and Human Trafficking, AKA better known as Futures Without Violence. You can join Lisa and really talk shop about ways to provide better TTA for your patients, again, experiencing IPV. Next up, we have the National LGBTQIA+ Health Education Center, and leading that group is Virginia Vedalago. And again, this is for you all focused on the LGBTQIA+ populations, especially, again, if you're working with Fenway already. They have a lot of great resources on kind of gender affirming care and also just cultural affirming care for the populations they serve. For the migratory and seasonal agricultural workers or farm worker health populations, we have Myra Reiter from Farm Worker Justice. So you can join that group, and she'll also be highlighting some of the resources from the other Farm Worker Health Network and TAPs. So that includes Health Outreach Partners, MHP Salud, the National Center for Farm Worker Health and Migrant Clinicians Network. And then next up, we have the Residents of Public Housing, and leading that will be Casey Ulrich and Emily Kane, and they represent the National Nurse-Led Care Consortium. The other NTAP in the room is going to be the National Center for Health and Public Housing, and I think I see Saki and Jose, so shout out to the other NTAPs focused on public housing residents. And last but not least, our friends at School-Based Health Alliance. We have Andrea Shore representing that NTAP, and that's focused on the school-age children for the youth and adolescents. So all you school-based health center staff or those focused on youth, please join Andrea. And for those breakout rooms, here are the instructions. So we'll have the facilitators do quick intros of themselves and their NTAPs. And then for you all, just quickly chat in the chat box your names and your organizations as well and titles. That way the facilitators know who's in their breakout rooms. And for 20 minutes, there'll be a live moderated discussion based on some key discussion questions that are aligned with our needs assessments and listening sessions. So again, you might diverge into other questions if there are burning questions for the NTAP facilitator or PCHC facilitator. So feel free to just make this a very lively and informal discussion. And there's a bonus here. If you all have resources you want to share with each other, because peer learning is a big factor in our TTA work, please do share that in the chat box, because we know that there are so many more of you that haven't been acknowledged yet that are doing great work at whether at the national, state, or regional level. So please do share your past webinars, your publications, your upcoming trainings. This is a way to collaborate even more through our HRSA Health Center program. And just to give you a preview of the questions, we're going to talk about, again, your experiences sitting in or facilitating SDOH training, some key screening for SDOH strategies, some of those upstream strategies that you're taking on in terms of leveraging your SDOH data, and just other ways to provide TTA. As Eureka mentioned, again, there's peer learning, there's doing self-paced learning, there's doing focused topics on populations or different criteria. So feel free to just share with each other what you can and collaborate on in the future. And then other questions you might run into, the facilitators will be leading that. So with that, I'm going to release the breakout rooms and you all get to self-select which room you go to. And if you want to come back to the main room and choose another breakout room, that's an option as well. So we'll do this for 20 minutes and then close out the session. So with that, let me end this slideshow. And your facilitators I mentioned will be ready to talk with you and strategize with you. So with that, please do choose your room. And again, if you want to come back to the main room, just leave your breakout room and then we can divert you to another room if you want to switch over. Thank you all.
Have to scroll down to look at the different rooms that are available. So please go ahead and do so. But if you have any issues, let us know. We'll be glad to help.
Yes. Thanks, Eureka. And people are slowly, and if you're staying in this room, you're going to be with AAPCHO, NACC, and ECE. So we'll give it about a minute for people to join their rooms. And if you have trouble going to a room, just let me know and I can assign you.
Albert, where would you like me to go?
Is that you, Lindsay? Hi.
Yeah. Hi.
I think I remember, did you want to go to Futures or you wanted to go sit in on another break?
I'm at your service. So
Oh,
you
no. Maybe you can join Heather and provide another perspective on the PCHCN.
Okay, that sounds good then.
All right. Thank you, Lindsay. Glad you can join. All right. So I still see there are 39 unassigned. Choose now or forever hold your peace. No, you'll be fine. So you're with AAPCHO, NACC, and ECE. We're focused on all underserved populations. So basically any population served by the Health Center program. So before I dive into our discussion guide, I just want to introduce our other facilitators. So you already know Eureka, but Joe and Ariel, do you want to quickly introduce yourselves?
Sure. Hi, everyone. Joe Lee here. I'm the Director of Strategic Initiatives and Partnerships at AAPCHO. I work really closely with the PRAPARE partnership team. So good to see everyone. And I see familiar faces. So good to see you. And I'll hand it over to Ariel.
Awesome. Yeah, my name is Ariel. I'm the program manager of the National Center for Equitable Care for Elders. When we were a part of the stakeholder meetings, we decided that older adults would be included in sort of the main breakout room, because we know that all health centers certainly have some patients who are over the age of 65, but there's a lot of intersectionality. They are so happy to be with you all.
Great. And am I missing anyone? Okay. we have a bunch of other people here. So with that, for you all, hopefully if you have video, feel free to turn on your cameras. We'd love to see faces in addition to hearing voices. But one of our first questions is kind of, could any of you tell us an experience you have participating or facilitating a SDOH training? And this could be from the past year or like previous years beyond 2021. What went well in that training is kind of the goal we want to peek into. What were your favorite aspects of that training?
I can jump in. It's Alyssa from Westway Community Health Center.
Aloha, Alyssa.
Hi, guys. Are you talking about trainings like us training our staff? Or are you talking about these kind of a training?
Both, because I think you're also, I know you're providing training to your staff to collect SDOH data more and more, getting buy-in from management, getting buy-in from senior leadership. So kind of what works for adult learners, you know, I think a lot of our work is relatable in that sense when we're working with clinicians across the country, or non-clinicians as well across the country. So what's working well for your health center?
One of the things that I got from a training from you folks was when we actually just laid out timelines and plans, when we started talking about SDOH screening and everything, and you folks pushed us to really think out all the different steps involved, some of the barriers that we would confront, some of the, you know, thinking about the challenges and also the assets of our clinic and really just laying it out. I thought that was the most helpful training I had ever been to, because we walked out of that training with like a concrete plan and timeline of what we wanted to do. And then in terms of training other staff, I feel like, speaking to your audience, you know, we presented a lot of trying to get buy-in for SDOH screening. So really targeting the audience that you're with. If it's the MAs, you know, you're talking about how we're finding out information to better care for this person. When you're talking to maybe financial administration, you talk about the money saving value of SDOH screening and implementation at the clinic. So really looking at your audience and building a presentation towards that. Thanks.
All amazing feedback, Alyssa. And I remember sharing some PowerPoint samples with you, which I hope helped, and you shared your PowerPoints with us, which we were able to share with other health centers in different states. So from Hawaii to the Dakotas, I feel like that's been very helpful. And rather than reinventing the wheel, we've been able to kind of do that collaboration work across the country. So thank you for all that you do.
Yeah, I just want to echo how incredibly important it is to know who your audience is and who you're providing the information to. This is something that has been echoed by other health centers across the country, as well as TTA providers. And I think it's something that we have learned in the PRAPARE training space is that, one, there's a huge difference, right, when you're talking to clinical and non-clinical teams, and those who are in leadership, right, like C-suite, and those who work on the ground. and I know I can say this because I used to work at a health center. You know, there were some clear, you know, like differences in understanding how certain things get done, right? And that's okay. That's just the nature of, I think, a lot of organizations. It's quite normal, actually. So when we talk about workflows, when we talk about implementation strategies, I think, and especially when you're training, right, whether it's your own staff, or if you're a TTA provider and you're providing training for direct service organizations, it's really important to keep in mind to ask, who is the audience, right? Who is attending? And one best practice that Albert and I and the PRAPARE partnership team have obsessed over is looking at the registration data. And in the registration data, we ask questions like, what do you want to learn about, right? Like, what is your level of knowledge? What is your perspective? And we ask for those titles too, so we know who's in the room. So that's something that that I think that's a really excellent point, Alyssa. So mahalo for your wisdom there.
Do we have other health centers in the room that want to kind of share their experience, either participating in or facilitating trainings on the ground with their staff, providers, patients? see if I recognize anyone else here.
Hi, this is Felicia. We're an urban Indian organization and we haven't yet started doing the trainings, but we would like to. So we're definitely just in the learning mode for what are the best practices, what are the landmines and things to look out for, because I'm sure there's some. I'm in a different community of practice for social determinants of health, and they just introduced like transportation services and health literacy screening as almost like precursors, or what they're terming universal screening, before the implementation of social determinants of health screening, such as using PRAPARE. And it's a lot, because to just screen generally and then do something specific, I just feel like it's all over the place. And so just trying to make sense of everything that's out there that we need to learn about in order to do this, because we want to implement it.
Thank you for sharing, Felicia. May I ask where you're located, what state or region?
Yeah, I'm in California, in Fresno, California.
Oh, great. Shout out. I think Joe's worked with some people in Fresno in the
Central
consortium.
Valley.
Yeah, Central Valley.
Are you part of the Central Valley Health Network, CVHN?
We're an urban Indian organization, so we're not at FQHC, but I do know them.
Oh, okay. Okay. Got it. Sorry. My apologies. Yeah, I mean, that's something that, yeah, I really appreciate how there has been an introduction to social interventions like transportation services, like you mentioned, because I think when we talk about, it's interesting because when we hear from health centers and community-based organizations just across the country about when we conduct social needs screening, how important it is to be prepared with resources and how unethical it would be to ask a question about a social need and you don't have, a response, right? And so I think it's wonderful that your organization, it sounds like they're committing to introducing key social interventions or resources, because I think that's a certain level of competency, right? I think that staff and frontline providers should have, right, at least a baseline knowledge of like who to refer to or who to contact or what resource to highlight. And so, yeah, I'm curious, is that a dedicated trainer in-house, or do you bring external agencies from outside?
Yeah, we're not even there yet. We have our internal work group and we have our selected tool. We know we want to implement it on medical and the non-medical side with youth and elders.
Okay.
So the training will happen across the board. But another question I have is like, who should hold this? And I've heard a couple of responses to that. Curious to know what you guys' 2 cents is. Like, who should hold social determinants of health?
Albert or others?
I know others, especially if you are collecting this information. We've heard it across the gamut. Again, it's sometimes just living within the health center, but then slowly and surely we're seeing data being shared externally with community-based partner organizations. And that is a whole another challenge, is like, what are they going to do with the data? It's coming from a HIPAA compliant environment into a non-HIPAA compliant environment. And so there's like patient privacy and confidentiality issues that are coming up more and more as we talk about data sharing across organizations. So I am curious to know, is anyone doing that work now, and how's that working in terms of data sharing and holding that data, to Felicia's point? And I'm going to call out some PCA and HCCN colleagues here. I see Jasmine, Alberta. Any best practices you're seeing in terms of how your health centers are sharing SDOH data across the state?
And something to think about too, I think, is, feel free for any of the health centers or community-based organizations or frontline providers here, feel free to share your thoughts in terms of who should have access to the data and why, or on the flip side, what are the concerns with data sharing? Because we hear that too. So we'd love to hear from you about, what are some benefits and also what are some concerns with holding or sharing data.
I'm sorry, this is Linda, and I'm sorry that I had to leave the room for a while. But I'm really concerned about data sharing in terms of confidentiality of the information. There are cases, there are situations where the patient can be actually harmed if data is shared and confidentiality is breached. So I'm concerned about that.
Thank you, Linda. And could you tell us a little bit more about, in terms of the confidentiality issue, what do you feel like might be some ways to navigate around that? So for example, would it be identifiable information, right? That might be a concern to share, or that might be disclosed, or is it other aspects of like other data elements or variables that might be more or less sensitive? What are your thoughts there?
I think that we need to be careful because on one side, we're talking about services that are provided by the health center itself. And you can be a little bit more controlled about your confidentiality in that situation. But when you have cooperative agreements with community partners, then it becomes a little bit more difficult for you to have that kind of control about confidentiality. So I'm concerned with that, especially when we're dealing with SDOH issues and so many of our contracts are with people in the community or are with organizations in the community.
Thank you, Linda. And sorry, Linda, can you let folks know where you're from? I know where you're from. I didn't realize.
You know where I'm from. I'm from the troublesome state of Florida.
Troublesome.
Yes.
What are you talking about? No, I'm kidding.
It's Florida, DUH.
And yes, Linda represents works in the Florida Primary Care Association. So thank you for your insights, Yuriko. All right, sorry, Linda. Sorry, I was looking at Yuriko's name and I said Yuriko. Yeah, I think, it's something that we have learned as well from, especially from folks who, direct service providers who are in need of resources outside of their four walls, right? And so how do we develop community partnerships with other organizations? And with those partnerships, how do we ensure that we have the right amount of the right information, right amount of information exchanged? And how can those cooperative agreements or memorandum of agreements or what are those other descriptors? And
MOUs.
Memorandum of understandings, right? We find that that's like a really a valuable resource for some organizations. Is that something that other organizations in this room here might value in their training and technical assistance, to know how to develop MOUs and contracts? I see a nod from Melissa. And feel free to chat in the chat box. Do you feel like that might be helpful in developing community partnerships to generate more resources for social interventions? So feel free to share your thoughts there.
Hi, I'm gonna pipe up. I
Please.
think that's always been a barrier with us for sure, is just the implications, of course, of HIPAA and sharing the health center information. So we've never really figured out a way to develop like a solid MOU system that's where we're sharing individual data. But also to speak to the other data question you had posed. So yes, I think if you folks could help us or help us come up with a training for that, that'd be awesome. But aggregated data, like we envision collecting our SDOH and sharing widely. And it's just because we come from such a rural area that nobody really focuses on our social determinants here. Like we have one homeless organization, we have one other, food organization. So I think for us sharing our data so that our community partners can use that data to go for grants and, build the services where we have the holes in our community and gaps. So
Yes,
I see that as super valuable because we are the hub. Like there is no other organization in town. We're a federally qualified health center. There's no other organization in town that people all go to, I think we probably have the most data of any organization on our island.
Thank you so much, Alyssa, for sharing that. I think that certainly sparks a lot of light bulbs and great ideas in terms of how we can tailor our trainings to provide perhaps guidance on how do you aggregate data and share that data in meaningful ways, like you said, and leveraging that data to secure additional resources, whether it's through the form of grants or how do we communicate that data to stakeholders that have an influence on policies and regulations and budgetary decisions. I'm looking at all the local city council folks who make decisions on where funds are spent. I do that a lot in my hometown in Oakland. It's like, what's our mayor spending their money on? Violence prevention. So I think you bring up a really valuable point. So perhaps, not only should we perhaps train and provide technical assistance around SDOH screening, but what happens after SDOH screening, that data, and the power of aggregated data, maybe not share disaggregated identifiable data because that's the confidentiality issues. I totally agree with that. But now we can, maybe talk about what do we do with the collective data and to advocate for areas that are often under-recognized or ignored. So thank you, Alyssa, for sharing those critical insights. Oh, did Albert kick everyone out?
I didn't. I automated it, so there was
automated
automation. Don't we love it?
Oh, nice.
We can automate our data and have pre-populated reports because that'll help
Joe
us
and
all.
Albert, this is Linda. Again, one of the important things that Alyssa was saying, though, was that when you are able to do these memorandum of agreement or whatever you want to call them, and you put a dollar value to that service, you can actually then calculate an estimate of what it is that you're bringing into the community. And that's very valuable, not only to the leadership of the centers, because they're interested to see what the return on investment is for the services that you provide, but it's also a great tool for when you go out and you do a grant application, because you can say there's so much hard cash and there's so much in-kind cash.
Amen to all of that, Linda. Couldn't agree with you more. Thank you for sharing those insights. Welcome back, everyone, to the large room here. I'll have Albert lead us in the closing and next steps.
Yes, I know we ran out of time. We wanted to make this an hour and a half, but we just also wanted to respect people's time as we close out some deliverables, especially if you have a project year ending on June 30th. So please keep in touch with all of us. We'll have a follow-up email with everyone's information. But I do want to point out that the Health Center Clearinghouse is a one-stop shop for you all to kind of get a glimpse of all the different TTA providers. And you can, again, go by special vulnerable populations type, focus on social determinants of health. And so there is a way to contact all the NTEPs who provide TTA around SDOH. And many of them were on this call today. So thank you all for joining. In terms of what's next, again, we're just going to quickly launch this poll just to let us know. Oh, sorry, can't launch that. Joe, are you able to launch the poll?
Yes.
Great. we hope, again, this is not the last forum that we could provide for everyone, but the publication will be coming out very soon once the Bureau approves it, and NAC will be sharing that with you all and disseminating that. And then for you PRAPARE users, we want to talk about the PRAPARE Tiger team, which is very EHR specific. So if you have any health centers that are having issues around NextGen, ECW, Epic, Athena, those are kind of bulk of our EMRs that we're working with very closely now with license agreements. Please check out the Confluence page, and I'll ask Eureka to put that in the chat box. And if you want to be a PRAPARE influencer, whether you're a PCA, NTAP, HCCN, or health center, please complete that SurveyMonkey. We'd love to partner with you very closely and start working on a national level if you are ready to do that national spotlighting of your work. And with that, just want to say thank you, thank you, thank you. We'll be in touch.
Yes, thank you so much, everyone. Thank you to all the fabulous NTAPs, PCAs, HCCNs, health centers, community-based organizations, and all other types of stakeholders for being here today. This has been just such a wonderful partnership and engagement opportunity. We see all your lovely emojis. Thank you. Please take the evaluation. We want to hear your honest truth about what you think about us. And good luck for all the CTA providers wrapping up the end of the Bureau year. Woohoo, we did it. We survived. And if you want to partner on SDOH screening and PRAPARE and all that good stuff, hit us up. You have all of our points of contact here listed in front of you. Thank you, everyone. Stay well, stay safe. Take care.
Enjoy your summer.
Bye.